Okay, I cannot advance. Why can I not advance?
If you can't by your computer, when you go to the left bottom side of the screen, there's small arrows.
The small
yes, around there, you're going to see small arrows usually when you click there. So,
okay.
yeah. Okay.
No disclosures. Thank you, Grace.
Welcome.
So I have disclosures. Pediatric care in low and middle income countries, it's estimated that up to 90% of the children in low and middle income countries do not have access to adequate care. Most of you know this, but approximately 250 to 300,000 children in low and middle income countries die annually because of deficiencies in care for their heart disease. Now, why is this? So let's take a look. This is a paper that was recently published in the Journal of Thoracic and Cardiovascular Surgery. And here you can see the blue lines, the blue in the hologram represent adult cardiac surgeons. And so we have the two disparities. We have the low income countries on the left and the high income countries on the right. The red bar is pediatric cardiac surgeons. You cannot even see pediatric cardiac surgeons in low income countries. So there are not nearly enough surgeons to serve the population in these countries. Now, why is that? Some of that has to do with the financial security and economic status of the countries that we're talking about. And so here you'll see displayed the GDP, which is the very top line in US dollars for these areas of the world, sub-Saharan Africa, South Asia, Middle East and North Africa, et cetera. The pediatric surgeons are the lower green line. And so in sub-Saharan Africa, you're looking at 0.1 pediatric heart surgeons per million of population. You get over to the Middle East, and finally, you have one surgeon per million of population, which is actually a reasonable amount of service for a population of 1 million. Now, this unfortunately cannot be made any bigger, but this gives you an idea of the number of pediatric cardiac surgeons per million of population around the world. And if you look at the Middle East is pretty well served with the exception of Lebanon and Yemen. But North Africa, as you can see, except for Egypt, has a bit of a problem. Morocco, Algeria, and Libya, we're looking at less than one pediatric heart surgeon per million of population. Now, the annual births per year actually, as you all know, determines the number of children with congenital heart disease that are born around the world. And this will give you an idea of how many millions of births occur in a number of these countries. And the birth rate is probably highest, as you can see here, in Egypt, in the Middle East and North Africa. However, Iraq does have a fairly high birth rate itself, as does Algeria and Morocco. So you're going to have more children born with heart disease per million of population because their birth rates are higher. Now, I'm not meaning to steal anything from Minister L. Oakley's talk, but this was a Sentinel paper that was actually published in 2006 in the Libyan Journal of Medicine. And this is the number of newly diagnosed children with congenital heart disease in Libya in 2006. Now, I'd like you to look at the bottom number, 2,000 children. Libya has a population at the time that this study was done of 6.5 million people. At the time the study was done, they had one heart surgeon. Now, I would argue, as would all of you that are cardiologists, that not all 2,000 of these children need surgery, but certainly at least 40 to 50% of them do. So you're looking at somewhere between 800 and 1,000 children born annually in Libya with surgical or interventional cardiology correctable heart disease. and a surgeon that was doing only 300 cases per year. Now, this is an interesting slide that I believe gives you an idea of the change in congenital heart disease occurrence between 1990 and 2017. And I'd like you to focus your attention on the very bottom line, which is the low-income countries. At 25.2 children per thousand of population, you're looking at a very significant number. It hasn't changed between 90 and 2017, but what has happened is the total number of births has gone up, so there are actually more children, but not more per thousand. Nonetheless, that makes it problematic when you only have one pediatric heart surgeon. Now, there is a very good correlation, actually, between the incidence of congenital heart disease and mortality according to the GDP of the country. And here you will see in 1990 that there was an increase in both mortality and incidence of congenital heart disease as you had a lower GDP. That increased substantially in 2017, and probably the reason for that was the accelerated birth rate in a number of these countries as compared to birth rates in the West. So we're going to look now at the actual number of cardiothoracic surgeons in North Africa and in sub-Saharan Africa. And I think what's important on this slide is that you don't even have 100 cardiac surgeons in sub-Saharan Africa. So out of that group of 97 surgeons, probably only 35 are actual cardiac surgeons, whereas in North Africa, you have almost 100 cardiac surgeons to serve the population there. So what are the problems in low and middle income countries for children with congenital heart disease? Well, we just pointed out there's an inadequate number of individuals trained to provide cardiac surgery in general, and more specifically, pediatric cardiac surgery. There are an inadequate number of sites for cardiac surgery. There are economic factors in a number of these countries. In sub-Saharan Africa, there is a huge brain drain. There are too few centers locally training. Magdi has a great center in Aswan and is building another one in Cairo. But if you think about the number of training centers that are located in Africa and the Middle East and North Africa, there really are not very many. Then there are political factors, local factors, regional factors, and national factors, which can certainly impact the care of children with heart disease because of budgetary constraints or shift in politics. There are transportation issues for patients in a number of these countries where the infrastructure is inadequate to allow the patients to actually come and go to the clinics in an easy fashion. And then in a number of countries, there are restrictions on medications. And that is certain medicines may not be registered in the country and therefore completely unavailable for the care of children with heart disease. We recently ran into this problem in Zimbabwe, where we were sending in a shipment of medicines for children with congenital heart disease. And a number of the medicines, which are routine in the Middle East, as well as in Europe and the United States, were actually not registered. And so we had to go through a process of registration for these medications just to import them into the country. I've been doing this since 1993, as some of you know, and have actually founded two different foundations. International Children's Heart Foundation from 93 to 2014, and the Novik Cardiac Alliance from 2014 until currently. And over the years, we've been able to identify some solutions that we believe are important to building sustainable programs in low and middle income countries. We believe that you need to identify sites with potential. So there must be local motivation, infrastructure, adequate human resources, and support. as I mentioned earlier, from the hospital administration, both the regional and national health authorities. We provide refurbished critical care equipment to cover deficits in equipment that sites that we choose to work in may have. We commit to long-term intervention and provide multiple trips per year. If you're going to make a change in the care of children with heart disease, specifically in the surgical care of those children, then you need to be available to teach on a routine basis. And that's why we make multiple trips per year. We also believe that the teams that go in should be stable in terms of the individuals from the visiting team, because this helps build relationships, and building relationships allows you to build trust with the local team members. And that is a very important component of building a sustainable program. We utilize the mentorship model for graduated responsibility of the locals as they progress in their knowledge and experience. And we provide educational support with lecture materials and conference attendance for the local healthcare professionals. Now, these are the sites that we have visited over the last 20-something years. The red sites are sites that are either currently being assisted or have graduated from the program and are now independent. The black sites are sites that are no longer assisted by us, but others have in those countries. So I have them broken down by the regions: Eastern Europe, Middle East, Sub-Saharan Africa, North Africa, Central Asia, South Asia, East Asia, South America, Central America, Caribbean. And so the total is actually 35 countries that we've assisted over the years, 57 different institutions, and this has spanned a 22-year time period. What sort of impact did we actually have on these places? So our total primary operations to date, sorry, Sasha, you were off by 510 kids. 9,490 children have received primary operations. The country that we've performed the most operations in is Iraq, with 1,212. The region that has received the most assistance in terms of operations is Eastern Europe, with over 1,700 children operated on there. And the greatest number of trips that we made in 1 year was 44 in 2013. And that year we operated on 784 children together with the local team. Now, let's talk a little bit about what COVID has done to impact our ability to deliver care, as well as the ability of a number of institutions in low and middle income countries to deliver care to children with heart disease. In 2015 to 19, we averaged 25 trips a year, almost 380 operations a year, and visited 7 countries every year. So as you can see, 7 countries, 25 trips. There were multiple trips made to each one of those countries. In 2020, we made 3 trips. They all occurred before the WHO declared this a pandemic. So those trips were made in January and February and ended in the first week of March, a total of 3. We've only performed 111 operations in those 3 trips. That includes, it does not include the 15 that we estimate that we're going to operate on in our trip to Lebanon in 2 weeks. So the total number of countries has been 2, Russia and Libya. We will actually make it to 3 countries when we get to Lebanon. We canceled 19 trips this year, averaging 25 kids per trip. Very significant impact that has had. When COVID became the pandemic and we started seeing closure of routine surgical practices in the United States, we as a group decided to conduct a survey of the programs that we were knowledgeable of in 35 low and middle income countries. There were more than 70 centers that were involved in this. We constructed a survey and sent it out, and over the course of a month, it was completed. The response rate by country was 61% and 67% for institutions. You can see the website here where this survey was published on CTSNet. So let me take you through this just a little bit. What were the restriction of services? And I realize this slide may be a little bit hard to see from a number point of view, but the colors certainly stand out. Almost 90% of the programs were asked by either the hospital or the government, which could have been local, regional, or central government, to restrict operations to those that were essential only. Those orders were issued as early as November of 2019. And I can tell you that that was in China, and that was countrywide at that time. Now, what was the impact on volume reduction? So we asked specifically, has your center been affected by the number of surgeries that it normally performs? And as you can see here, 96% of the centers responded yes. Yes, we've noticed a decrease in our volume. And then we asked what was the percentage of reduction? And as you can see here, there was very significant decrease across the board in the number of cases that sites were performing. Now, all of us know that there are children that are presented to us, typically newborns, sometimes infants as well, with critical heart disease that require urgent to emergent operations. And so we asked the question of, did you continue to perform critical congenital heart disease cases during the pandemic? And fortunately, 81% of the sites responded in a positive fashion. So approximately only 19% of the sites had a reduction in their critical cases. The volume of neonatal surgery, as you can see here, we asked whether it remained unchanged or not. And 53% responded no, it actually has gone down in our center. So critical cases, for the most part, were performed, but there was a decrease in neonatal cardiac surgery. Now, for all of us that are involved in this, of course, we're all worried that our own healthcare team might contract COVID, or that because of the pandemic and really, if you think about the huge change in the transportation network, a lot of planes are still not flying. So how did that interrupt the supply chain? So we had 69 out of 70 sites respond that there was testing, that answered the testing question. And 48% said, no, we don't test anybody before we operate on them. Whereas 52% did believe in testing. Then there was a question about whether or not there were shortages of supplies. And the supply chain basically held up. 64% of the respondents said, no, we did not have a problem with supplies necessary for carrying out pediatric cardiac surgery. Now, as you know, here we are, we're in a Zoom meeting now. And so one of the questions that we thought would be important was, how did the sites handle their weekly cath cardiac surgery conference, or their echo conference, or their morbidity and mortality conference? And as you can see here, 61% of the sites actually did use some form of video conferencing. And in 38.6% of the cases, we really didn't get a response. But as you can see, there was a substantial number that actually used encrypted methods to protect patient identity for their video conferencing. So video conferencing was used widely, both encrypted, non-encrypted, and local. So the last question that we asked was, what do you think the overall impact of COVID is going to have on the volume of your pediatric cardiac surgical program in 2020? And only 11% said it was going to be insignificant. And almost 30% said they were going to lose more than 100 surgical cases per year. Now, obviously, if you're an institution that's performing 900, 100's not maybe such a big deal. But if you're an institution performing 300 cases a year, you just had a 33% drop in your volume. So most of these programs were substantially impacted, from as few as 50 to more than 100 cases were going to be lost this year. So what do we have to say in summary about cardiac surgery in low and middle income countries? Well, there are literally hundreds of thousands of children born in low and middle income countries where there's deficiency in cardiac care. Deficiencies exist across the board: human resources, infrastructure, equipment, supplies, and financial support. But we believe that program development can occur with adequate support. COVID-19 has caused a severe disruption in the ability of us to assist, as well as local teams to carry out the care required for their own children with heart disease. I'd like to thank the Congenital Heart Academy for the opportunity to present this information. And I know we're all working hard to get back to some degree of regularity so we can help our patients. Thank you very much.
Thank you very much, Dr. Novick. It was really, really amazing. As you know, me and Sasha, we like a lot mission trips, and we truly believe that is very important. I don't know if you know, but I was going to travel with you for Lebanon in 13th of April, the first trip that was canceled. I was going to be one of your intensivists. Inshallah, next year.
Yeah,
inshallah, next year.
Inshallah,
so
absolutely.
Thank you very much for... I hope so, yes. So guys, please type your questions on the Q&A chat box. All the speakers are going to be very, very happy to answer them during the webinar. And we are going to have a break in the middle of the webinar. So we are going to have some discussion, and we are going to answer some of your questions live. So please participate in chat and type your questions. Other things is that we have amazing activities for the next couple of weeks. I apologize because my internet connection and my computer are broken, so I couldn't show you online, but I'm going to type on the chat box the link for the registration, and you're going to receive them on email as well. But we have Dr. Anderson. We have one meeting about the neurological outcome of our kids. We are going to have one meeting only about anomalies of the coronary arteries on the 23rd. We have a lot of things to come. So I really hope that you all can join us in the next 2 weeks. You're going to receive all of that by email. And now I'm very glad to introduce the coordinator of this meeting today, Dr. Halas, who is the president and founder of Pan-Arabic Congenital Heart Disease Association, which was established in 2002. She is a professor of pediatric cardiology and Mansoura University in Egypt, and vice president of the Egyptian Working Group of Pediatric Cardiologists. Be welcome, and thank you very much for organizing all of that.
Thank you, Grace. It's my pleasure and my colleagues' pleasure to coordinate this meeting with the Congenital Heart Academy. I know you're doing great work in approaching different organizations in the world doing the practice of pediatric cardiology and cardiac surgery. Here, my colleagues are the leaders of practicing pediatric cardiology and cardiac surgery in the Arab world. And this is not the usual type of practice. It's a practice in the turmoil zones of the world, as we have set the title. So in Iraq, in Libya, in Yemen, there are the war zones right now, as you may all know. and also in Saudi Arabia, in Egypt, in most of the Arab countries, we have difficulties in recognizing the congenital heart disease patients as early as we should. So we have presentations that will tackle this subject too. So our first speaker is Dr. Saad El-Hamash from Iraq. He's a professor of pediatric cardiology and in the Faculty of Medicine, Baghdad University. He's the head of the Congenital and Structural Heart Disease Department, consultant of Interventional Cardiology, Ibn al-Bitar Cardiac Center, Baghdad, Iraq. So please, Dr. Saad. Dr. Saad. I think he's with us.
He might have as the microphone muted. Hala, can you ask to unmute?
Not. I asked him.
Okay, we can go further, Hala, and let me introduce Dr. Rida Al-Okli.
Yes, and then we can Dr. Saad. Okay.
Okay, I think I will introduce Dr. Rida Al-Okli to present the Libyan experience and difficulties in establishing pediatric cardiology and cardiac surgery service. Dr. Rida Al-Okli, he is a senior consultant cardiothoracic surgeon and head of the cardiac center at King Abdulaziz Hospital in Taif in Saudi Arabia. Most welcome, Dr. Rida. It's my pleasure to introduce you. Go on, Dr. Rida.
Assalamu alaikum wa rahmatullah. Great many thanks to the Congenital Heart Academy and to Pachda, with particular reference to Professor Hala, Sasha, and to Milad for their invitation, for their kind invitation. I have a great pleasure to be able to share with you some of our experience about cardiac services in Libya in particular. Although I'm officially the head of the cardiac center in Taif, but I came here in the midst of COVID-19, and I had to unfortunately change plans. And I'm talking to you now from Benghazi because of the issue. I couldn't fly back with ease. I have no disclosure except that I'm an advisor to the United Nations Development Board. Cardiac surgery is easy to do. You can choose to pick slowly at it until it cracks down, for sure, or you can fight your way out of it, which is the favored method for most cardiac surgeons, or you can get someone else to do it on your behalf. I had the pleasure of contributing to developing a number of cardiac services around the world. The first of them was in Brunei back in 2003, and it's a great achievement I'm proud of, that we managed to do the first 100 open heart operations with zero mortality. Following that, we had a chance in 2006 to start cardiac surgery service in King Fahd Medical City. And I'm glad that that center is now King Salman Cardiac Center, is up and running and is one of the most recognized centers in Saudi Arabia. As William have pointed out, the World Bank sees us as shown in this slide. Pink countries or pink spots are high income countries, more than $12,000 per head per year. And the green are the upper middle income countries between 4 and 12,000 per year. Low middle income countries, 1 to 3,000 or 1 to 4,000 per year. And low income country, less than $1,000 per head per year. So from the outstart, if you're born in one spot, you would realize that, as Bill Gates said, life is not fair, so get used to it. If you were born in one of those green or pink areas, and you had well-trained healthcare workers, and if the other speaker is back with us, he'd like to take over, I have no problem, Milad. Or shall I carry on?
Carry on.
Right, thank you. Right, so if you had a good health system, which is often based on these 6 pillars, which is good healthcare workers, access or free access to medicine and technology, strong governance and leadership, good health information system, good financing or adequate financing at least, leading to adequate health service delivery. Then you would be fortunate to enjoy more than 99.5% 1-year survival post surgery if your congenital heart disease required surgical intervention. Right. However, not only the 6 pillars we have referred to, which have been recognized by the WHO to be the main pillars for a health system, security is very important, because we will not enjoy security without development, nor development without security, and neither without respect to human rights, as once said by Kofi Annan. Since the failed experiment of Mrs. Clinton and her entourage back in 2011 in the Arab Spring, the Libyan health system has collapsed. The experiment of Ms. Clinton was just to remove some of the dictators, but unfortunately, it has backfired in many ways to many people. This is a WHO assessment of the Libyan health system back in 2017, and it shows you how badly the health system has been affected. Out of 97 major hospitals, 80 are partially functioning, and 17 of them were totally closed or dysfunctional. And out of 1,300 primary healthcare centers, again, just over 1,000 were partially or fully functional, and 273 were non-functional, and so on. The number of beds were low, was down. Only 39% of the beds available were in a functional status. And that is the chart that have been shown by Professor William. He knows it too well. Every year we have more than 2,000 live births with congenital heart disease, half of whom would require surgery. And suffice it to say that in the year 2020, for example, the number of kids who required surgery and had surgery is no more than 100 cases in total. And we have shortage of numbers of surgeons. As William said, we have only 1 pediatric trained cardiac surgeon in Libya. You can see him in the picture. He is Dr. Hassan Maghour. And you can see that his support is limited so much to the point that he has to learn how to do echoes, and he's doing his own echoes. So faced with that imbalance between increased demand for health service and cardiac service against a broken health system with poor funding and lack of transparency, or corruption, as some people might like to call it, lack of security, and even lack of trust of the patients to the health system in that country. Faced with that, you have to turn around to people to friends that you know, and those you don't know, who would one day turn out to be some of your best friends. And in fact, I approached a number of our colleagues, Dr. Abdurraouf, and I even contacted Dr. Professor Yaqub. But I was fortunate enough to get an email from William back in 2011 to say that we are willing to support Libya in pediatric cardiac surgery service during the war in 2011. We continued to communicate, and eventually in March 2012 was the first trip that William made to Libya. And since then, nearly 1,000 operations were performed, mainly in Benghazi and Tobruk, was in the eastern part of Libya, and more recently, last year, in Tripoli, about 219 cases, with a mortality rate of 4.85%. Of course, the challenges with these organizations is that some of them come in with influence from politics of their local governments. In 2014, we signed an MOU with IMC, which is one of the organizations dealing with supporting health systems in crisis, who did very well in 2011. And we were hoping that they would carry on to support the Libyan health system 2014 and beyond. But unfortunately, due to some political issues, we're not sure. It is actually mainly funded through USAID, and US, at least foreign policies, were not very much in favor of the Eastern government, which was recognized in 2014 all the way up to 2016. So we had very little support from this organization. Accident Organization is another one which came from Italy, and they will help us to set up a major trauma center in the eastern part of Libya in the years 2015 and 2016. And they managed to treat over 1,000 wounded patients during the war against terror in Benghazi and in Derna. But unfortunately, they were called out of the country or out of Eastern Libya very quickly by the end of 2016 because Italy made a decision to take a military hospital into the other side of the country, and they were worried about the backlash of the people in the East, and that might affect the performance or even the livelihood of the people working in emergency. Even with William proved to be a very efficient coordinator for getting pediatric cardiac surgery done in Libya, much more than what we could have done without his team. But his trips actually, in the beginning, we had, in addition to cardiac surgery support, we had good cardiology support, invasive cardiologists. But in the latter visits, I think we have missed that. And maybe one of the questions that William can help us with is how we can make not only cardiac surgery, but also invasive cardiology to go hand in hand with the visits that Professor William Norvig is doing to Libya. As you know, the political division with violence often lead to deterioration of services in general, and health services one, leading to staff demoralization, damaged infrastructure, and lack of resources. And lack of resources will make it difficult for you to have any decent program, even through charity, because eventually charities would run out of money, and you should be able to at least make sure that you can afford to buy their tickets to come and help you. To me, it's very unreasonable to expect a charity to be with you most of the time and be able to travel to you on a regular basis. At the same time, you expect them to buy their own tickets, and also you'd like them to buy the items that are short in your health system to perform pediatric cardiac surgery or otherwise. While I was complaining about the lack of ability to fund a stable and sustained cardiac service in Libya for multiple reasons, since the division and since the introduction of the GNA, which is recognized by the international community in Tripoli, our government became very invalid, and we didn't have access. We never had access really to hard currency. We never had access to buy medical supplies using US dollars because the central bank was in Tripoli and was hijacked from the very first day our government was instituted in the East. While I was in a meeting in London in the summer of 2019, I met Professor David Wood. He's a professor of peace practice and peacemaking at Seton Hall University in New York. He's Irish British. He's a fantastic diplomat, and a great negotiator. And we started thinking about health diplomacy as a bridge for peace. And we were thinking what would be the best tool or cover to use for health diplomacy. And these are the essential principles that should be present in health diplomatic activities. They should work with all sides. They should be based on best available information and work according to geographical boundaries, not political boundaries. It should be based around need. And I think there's nothing which is more visible to the people that we are in need for than pediatric cardiac surgery. And we started submitting a proposal to get funding for 2 full-time pediatric cardiac surgery programs in the East and the West, together with the support of Professor William Noble. But while we were doing that, of course, COVID-19 came. And COVID-19 came, and you can see this is the diagram here showing Libya as one of the worst affected countries now from COVID-19 in terms of number of cases per million population, compared to other countries in North America and South America and in Europe, except that the Libyan health system was broken. By the time COVID-19 was here, less than half of our hospitals were ready to cope with an emergency health service. So we have changed tactics, and we try to focus on COVID-19 as that tool to get the health diplomacy up and running. And we had our first meeting between doctors in the East, South, and West back on the 12th of September. And that was the first time that doctors from the 3 parts of the country were able to meet and talk freely and make a statement, a joint statement between them to say that we are in desperate need to unify our efforts to combat COVID-19 and improve the health service that is required by the people. And that is really the first step in what we call health diplomacy. First one is to look at mediated exchange between experts and between healthcare workers. And we managed to have 2 meetings of this, and the third one is coming next Saturday, where we invited Professor Ali Muqdad from the Washington Health Institutes for Health Metrics. He will talk about expectations of COVID-19 cases for the next 3 months in Libya, which to me is a very, very important development, and is quite appropriate for people to come and listen to see the dilemma that we're going to face in the next few months. We also managed to get administrators from both Ministry of Health in the East and Ministry of Health in the West, again, for the first time since 2012, to get, or 2014, since the split of the government, to be able to get people at the administration level within both ministries to sit down and talk and discuss on how to combat COVID-19 and agree on certain principles, for example, to get a unified protocol in the fight against COVID-19. So really, the need for pediatric heart surgery is pressing, but also we have a big issue with NCD, because one of the main problems with COVID-19 is negative influence on the care provision for patients with diabetes, with heart disease, patients with lung disease, and as well as other chronic illness. And unfortunately, Libya is the worst affected also by trauma. And this data from 2015, and you can see that Libya has 73 deaths per 100,000 population per year, which is more than double to the next up and running or runner-up to it, which is Thailand, about 36. All these, including dying from trauma in the war period in 2011, have dropped significantly the life expectancy of Libyan people, whether male in blue or female, from 70 to 75, all the way down to 50s. And I think that with COVID-19 now introduced, I suspect that the forecast for life expectancy for the Libyan population will be significantly less than what it is. With that, I thank you very much, and we'll be happy to entertain any questions if you like. Thank you.
We don't hear you, Harlan. Unmute.
Thank you, Dr. Reda, for this nice talk. I'm happy, as I understood from your talk, that now you are indulged in the negotiation in Libya now, trying to sort things out between the two parties.
Correct, correct. So using health diplomacy.
Okay, this is the health diplomacy we're talking about. So now a pleasure to introduce Dr. Sadeh Al-Amash from Iraq. He's a professor of pediatric cardiology in Ibn al-Bitar University in Baghdad. So Dr. Sadeh, yes.
Bismillah ar-Rahman ar-Rahim. Let me express my thanks for Pachda and for organizer to give me a chance to talk about our cardiology, cardiac surgery, and pediatric cardiology in Iraq. And I will start with the introduction. You know that the quality healthcare is a complex, multi-dimensional concept. The quality healthcare defined as providing efficient healthcare services according to the latest clinical guidelines and standards which meet the patient need and satisfy the provider. And this can be expressed by the principles of right, is that to the healthcare to providing the right healthcare services in a right way, in the right place, and the right time, by the right provider to the right individuals for the right. There's many factors can affecting the healthcare, including the patient factor, physicians, and environmental factors. Really, if we talk about the first of all the socio-demographic, demographic and the practitioner knowledge and the technical skill, and the physicians should improve their competence, attitude, knowledge to deliver high quality medical services. And if we talk about our situation here, that the physician need continuous training to improve such qualities, and especially in the cardiac surgery, the training should not include the surgeon, but as a team, including the anesthesiologist, perfusionist, intensivist, and the medical staff. And most of our countries lack of such regular program of training, and this reflects in the limited progression of our cardiac services. Also, it's important to about the physician factors, which include the motivation and the satisfaction. And they abbreviate in 9 organization factors that influence their motivation and the job satisfaction, including the payment, working environment, leadership, organization policies, co-workers, recognition, job security, job identify, and others. And most of these factors is absent or to the low degree in our countries, and this make most of our training doctors may leave their countries to have a job in other countries in the Gulf or even Western countries. And this reflects badly to the services to our patients. The environmental factor include the healthcare system, and you know that the most important factor which can affect the healthcare is the instability. And the most prominent example of the instability in Iraq, that all the last 30 or 40 years, there's no instability, and this reflects badly to the healthcare system, which can deliver the health care for the patient. Again, the resources and the facilities usually in our country is limited resources because of the many wars and because of the embargo, and then after 2003 because of the corruption. So that limited resources reflects badly to our health care services. In addition, that as a physicians, you need to be supported. You need a good nursing staff. You need a good lab and other supporting services, which is mostly absent in our countries. You know, to have a good services for the patient with a congenital heart disease, it is you have two wings: is the interventional cardiology and the cardiac surgery. If we talk about the cardiac surgeon in Iraq, the father of the cardiac surgeon in Iraq is the Professor Yusuf Al-Nu'man, which had the first cardiac surgery since 1963 in medical city in Baghdad. And at that time, the cardiac surgeon in Iraq is one of the best in the Middle East. That the many prominent politicians come to have a cardiac surgery in Iraq. The Bourguiba, the Tunisian president, and Idi Amin from Uganda. The first factors which affect the progression of the cardiac surgery and other health care system in Iraq is the Iraq-Iran war, which extended for 8 years from 1980 to 1988, where the care for improvement and support were very limited. And then we had the big shock in the second Gulf War at 1991, when the Iraq occupied the Kuwait, where in this war most of the infrastructure in Iraq was destroyed, and this again affected badly the health system in Iraq. And the suffering years is the years of embargo from 1991 to 2003, where we as cardiologists, we lost thousands of patients with the congenital heart disease because the limited services in Iraq and the impossible to send these patients outside. And sorry, we lost thousands of patients because of this embargo. In addition, that as doctors, we can't contact the outside Iraq. We have no training. We have no attend any conferences, and this reflects badly to our cardiac surgery and interventional cardiology. But again, although this years of suffering, we have two events which later on we showed have impact on our cardiac services. That the first of all is that all the limited sources was collected to establish the biggest cardiac center in Baghdad. That is the Ibn al-Bitar Cardiac Center in 1983, where it is the core for the cardiac surgery and interventional cardiology later on in the next years. And the second event which maintain the cardiac services in Iraq is the 1995 established of the subspecialty cardiac board certificate, which started at 1993, and after it is subspecialty, that's mean after to have a general pediatric or general medical board, you go into 3 years program for the subspecialty in cardiology, including pediatric cardiology. Until now, we about 30 candidates graduated from this board certified program. Really, the pioneer of the pediatric cardiology, he is an adult cardiologist, but he's the pioneer, Dr. Ja'far Al-Kuwaiti. He died at 2001 because of the cancer, and we remind him always by his obituary.
والسرطان ينحشني يخيط لي كفن يهشم أضلعي يجفف أدمعي يقتات من كبدي فيقتلني ولم أمت لأن في أنفي شموخ الصالح وفي دمي عاصفة تنسف من ألحانها القصائد سأصنع من جليد الصبر مفتاحا إلى القمة سأصنع من جليد الصبر مفتاحا إلى القمة سأرقاها وأرسي فوقها علم أنا الجندي يا وطني أنا العز أنا النصر أنا المجد أنا الفخر أنا ابن الرافدين الأصيل الحر أنا ابن الكوفة الحمراء يا وطني.
And what during 2003 war, whatever you call it, we have destruction of most of the infrastructure, especially in Baghdad, including Ibn al-Bitar Cardiac Center. And this is some of the photos which at that time, and would take a few years to 2 to 3 years for this cardiac center to re-establish again. And we re-established again, and the cardiac services re-established after the destruction in this biggest center. And what happened after 2003 were really, strangely enough, that the interventional cardiology progressive well, while the cardiac surgery is still at stationary or even deteriorating. So in terms of cardiac surgery, we still do the same procedure which done since 70s, including the ASD, BSD, and tetralogy of followed surgeries, and even the result is not up to standard. And still, till now, we don't have surgery for small weight and age, no surgery for complex congenital heart disease, and there's no even palliative surgery such as PI banding, BT shunt, or even Glenn surgeries. And we can diagnose some of the factors which make the cardiac surgery stationary in our country, that the lack of the specialty of authorization for the congenital cardiac surgery, cardiac anesthesia, pediatric intensive care, and the trained ICU nurses. This is reflect badly to the situation of the cardiac surgery in our country. While the interventional cardiology, the first workshop of the transcatheter closure of PDA and ASD was done by Dr. Hujazi and Dr. Ali Al-Halabi, 2001. And then after 2003, the progression continues. So we now in our centers, we did transcatheter closure of ASD, VSD, PDA, and we can do balloon dilatation of pulmonary stenosis, aortic stenosis, coarctation, and Rashkin for DTGA. This limitation of the cardiac surgery really motivate the interventional cardiologists in our centers to improve their skills to do a full spectrum of interventional cardiology. So many procedures which not well consensus worldwide, we established in our centers, such as coarctation balloon angioplasty in the unit of the infant, and the program for transcatheter closure by off-label the devices for the VSDs, and balloon dilatation for the RVOT in tetralogy of followed, where they have a recurrent spell and cannot wait for the surgery. We have experience to have RVOT without stent. Really, during these years, and because of the many graduated candidates, we established about 8 cath lab where full interventional cardiology done in Iraq. These 3 centers in Baghdad and many centers in other countries, and now at about 10 centers all over the Iraq. There's a special experience in Iraq that after the 2005, there's a program by the MOH, Minister of Health, to send the patient with a congenital heart disease where surgery cannot done here inside the Iraq, to send them outside, mainly in India and Turkey. And although this experience saved thousands of life of patients from to send them outside to have the surgery, but it is still the effect for the improvement of the cardiac surgery in Iraq is so limited. In the era of COVID-19, this is instead of evacuation program for the patient to be sent outside Iraq, we try to change to recruitment of the surgical team to come here and to do their with our surgeons, and we hope that will improve the quality of the services in Iraq by improvement of the experience of our surgeons in our centers. And thank you very much.
Thank you, Dr. Sadiq, for this nice talk and overall covering the overall situation in Iraq after the war. With our best wishes to make progress after having peace, we hope, in Iraq.
Amen.
Inshallah. And the next presenter is Dr. Ali Al-Akhfash. He's a consultant pediatric cardiologist in Prince Sultan Cardiac Center, Al-Qasim. He's originally from Yemen, and he's going to talk to us about the Yemen experience in establishing the pediatric cardiology and cardiac surgery service in Yemen. Yes, Dr. Ali.
Okay, thank you. Good evening, everybody. Thanks for the organizing committee giving me the chance to speak about the challenges of pediatric cardiology service in Yemen. Actually, we know that the incidence of congenital heart disease or the incidence of diseases in general equal the number of new affected persons per unit of time or population. And the prevalence is the number present at any time, which is the difference between the incidence and those who die in the same period. Congenital heart disease is the most common birth defect, affecting almost 8 to 12 per thousand live births each year, and they are classified into three main categories according to the severity of the congenital heart disease, including trivial or mild congenital heart disease, in which the patient will not require intervention or might require intervention later in life; moderate congenital heart disease, in which the patient will require cardiac intervention the first year of life; or severe congenital heart disease, in which the patient will be either in a critical condition and will not be able to discharge the patient from the hospital, like patients with prostaglandin-dependent congenital heart diseases, or having a complex VSD or AVSD or coarctation, in which the patient might develop complications or die before reaching the first or second year of life. Also, pediatric patients are prone to develop acquired heart diseases, including rheumatic heart disease, which is still a highly prevalent in countries like Yemen, as well as other acquired cardiac diseases like cardiomyopathy and arrhythmias. So pediatric patients, it is necessary for optimal outcome to have a timely intervention, and this might reduce the duration of pre and post-operative stay. Many pediatric patients with congenital heart disease in developing countries may die or develop complications while waiting for intervention. And the incidence of congenital heart disease can be estimated from the birth rates, incidence, and number of expected survivors with or without treatment. For the WHO recommends that for a population of 2 million, a pediatric cardiac center should perform 300 to 500 procedures annually. The need for cardiovascular services in middle income countries is greater than in low and middle income in other countries because of higher birth rate and the burden of acquired heart diseases. In developing countries like Yemen, congenital heart disease is not considered as a health priority. And these countries, and including Yemen actually, are still struggling to provide the most basic health care to their citizens. So many children with congenital heart disease in Yemen die or develop complications while waiting to have interventions. Yemen is a country at the southern end of the Arabian Peninsula in Western Asia, and the area is about 530 square kilometers, and the capital cities are Sana'a and Aden. The estimated population of Yemen is almost approaching 30 million, and the Yemen has one of the highest fertility rate at around 5 children per woman. And it is expected by 2015 to have a population of 60 million in Yemen. As of 2013, the budget of Yemen is consisted of almost 8 billion US dollars. And still this, there is a high debt and also a high inflation rate. The health system in Yemen is still fragile. There is poor access to basic and obstetric health care, poor access to clean water sanitation facilities, and poor access to food and shelter. A lot of conflicts and war. There are economic crises, still a high rate of communicable diseases, still a high rate of children under 5 continue to represent more than a quarter of all suspected cholera and acute watery diarrhea, still a high rate of infant mortality rate. And there is a poor government organization, corruption, lack of stable government, and ongoing wars. Healthcare in Yemen is still severely underdeveloped. The total expenditure on healthcare constituted almost 4% of the gross domestic product. Only 3 doctors are present per 10,000 person, and only 0.6 hospital beds available per 1,000 person. And the healthcare services are scarce in rural areas. This is from WHO data indicators. There are competing priorities: poor structural organization, lack of financial resources, lack of trained personnel, and we have only 4 pediatric cardiologists actually present now in Yemen, 3 in Sana'a and 1 in Al-Mukalla. And the absence of stable training and educational infrastructure, and high cost of cardiac devices and equipments. And this will affect the sustainability of any health services. Also, there are incomplete or partially qualified local team, low health workers payment, and if you believe it or not, they didn't have their payment for the last 3 years. And also one of the problems is that trained staff migrate to better postures and incomes in developed countries. To estimate the incidence of congenital heart disease in Yemen, we have accrued birth rate in Yemen of about 31 live births per 1,000 inhabitants. So we expect to have a total 900,000 new births per year. We can estimate the incidence of congenital heart disease in Yemen to be around 3,000 to 5,000 per year. So at least half of them will suffer from severe congenital heart disease and will require intervention in the first year of life. So the prevalence will be higher than that. Cardiac services in Yemen are dominated mainly by adult cardiologists. We have a pediatric cardiology service, which is not that well structured. And we have these services are mainly in governmental hospitals, in cardiology clinic with internal medicine or cardiac centers, or in private sectors, but there is no dedicated, fully equipped private cardiac center. We have cardiac units in private hospitals and OPD services. Cardiac centers in Yemen, we have three. Actually, we have three cardiac centers in Al Thawra Hospital, Military Hospital, and Al Kuwait Hospital. And no cardiac centers in other areas of Yemen, only in Sana'a. In private sector, there is no dedicated fully equipped private cardiac center, but there are, we can see there are cath labs and OR, but they are not fully equipped cardiac centers. And there is one now there is one charitable cardiac center, Nabd al-Haya Cardiac Center in Al-Mukalla, Hadramaut. Pediatric cardiology service in Yemen is mainly served by charity missions. And these sporadic missions, mainly by full congenital cardiology team, including cardiologists, cardiac surgeons, anesthetists, intensivists, perfusionists, nurses at various intervals, or by mini missions like missions for cardiac cath. And the important thing in these missions is the sustainability. If they are sustainable and continuous, they will provide a good care and service for pediatric cardiology. The primary goal of these charitable cardiac missions is to provide good quality patient care and to educate the local team to create sustainability. And success is best achieved with a structured partnership between the visiting team and the local team. We in Yemen, we get a lot of charity missions from Italy through Professor Bruno Morzi and his group. And also we received a lot of missions from Jordan, Egypt, Germany, and Turkey. And the most consistent charity missions are coming from Saudi Arabia through a lot of groups of physicians, cardiologists, cardiac surgeons. And the most consistent charity missions performed in Yemen was by Professor Jamil Al-Adha. And now we have this private charitable cardiac center in Al-Mukalla. It is called مركز نبض الحياة لأمراض وجراحة القلب بالمكلا. And this charitable center was done by this man, Muhammad Bashaib, and now Dr. Professor Abdul Nasser Minbari, he joined this center and he's doing a great job there. And now King Salman Humanitarian Aid and Relief Center, now they have agreement between the center and also between MOH of Yemen. And they conducted many missions to Yemen. And just this week, if you believe that, we have 3 physicians in this center, and they did in the first day 13 cardiac caths. And during the last 3 days, they did 39 cardiac caths. It is a business missions targeted to do pediatric cardiac interventions. So in conclusion, the incidence of congenital heart disease in Yemen is unknown, but expected to be high. There is still a high incidence of acquired heart disease, including rheumatic heart disease. Pediatric cardiac patients are poorly served in Yemen. Charity missions are effective in reducing the burden of congenital heart disease. And the presence of established cardiac centers with welcoming local team and authorities are important prerequisites for the success of such missions. And many missions or short trips by interventional pediatric cardiologists and cardiac surgeon might help a lot, and this might reduce the cost of moving large teams and could be more practical for continuation of missions. Thank you.
Thank you, Ali, very much. Thank you, Rida and Dr. Sadiq. It was an excellent talk, actually, highlighting a lot of points in our region where we have war and we have troubles to cover the pediatric cardiac surgery and cardiac surgery in general. I just want to add a comment to the last talk where Dr. Ali, the center or the private center, charity center, Nabd al-Haya, actually, it is a very good indicator that if anyone wants to do something, even in trouble area, he can do. the guy who Dr. Ali pointed on, his name Muhammad Bashaib, actually he is a cardiac patient in the bottom. And he sacrificed his life in the last 30 years to do charity mission in Yemen and ended by building this center, very advanced. Okay, I think we will continue for next, which is a continuity actually to what Ali stopped in the charity mission. There is a lot of charity mission done in Middle East and in Arab world, in Africa by Arab cardiologists. And now we will hear to our next two speakers who will talk about challenges in charities run by Arab cardiologist team. First speaker is Dr. Jamil Al-Ata. He will talk about technical challenges in performing a charity. Dr. Jamil is a senior consultant. Sorry, somebody has to mute. Hello. Dr. Jamil Al-Ata, he's a senior. Please, everybody should mute his line. Okay, I continue. Dr. Jamil Al-Ata is a senior consultant in division pediatric cardiologist at King Abdulaziz University Hospital in Jeddah, in Saudi Arabia. He will talk about technical challenges to perform the charity. Most welcome, Dr. Jamil.
Thank you, Milad. I hope you do hear me well. I didn't hear all what you said. Are you hearing me?
Yes, we are hearing you.
Thank you so much for this invitation. I'm very pleased.
But we don't see your slide. You need to share.
Yeah, I'm coming with it.
Okay.
Sure. So we'll share with you. راحت البرزنتيشن.
مش مشكلة ننتظر يا جميل. We will wait for you.
Yeah, I have I just opened it and then it closed again my presentation. Just a second.
You need to ask.
You can let Abdul Rauf start.
Okay, Abdul Rauf, are you ready?
I'm ready also now if you want.
Okay, continue, Jamil. You need to share your screen only.
Yeah. Trying to share the net is an issue.
We see your screen, but we don't see the presentation. We see the list.
Yeah, it's coming.
On USB.
You see it now?
Not yet. We see your USB, but I think it will come. If you see it, you can continue. We will see.
Because I can see it well.
The first slide was in, but I don't think what happened afterwards.
I think you need to close and open again, Jamil.
Okay, so I'll stop sharing. And I'm going to share again. You see it now?
Yes. Yes, go on.
Okay. So, sorry for the delay. I'll be talking about the more technical challenges. We have established a group of pediatric cardiac surgery and pediatric interventional cardiology services throughout the past 12 years. 1 second, give me please. I cannot move the slides again. This is okay. And since 2008, our group, which is a multinational group that has been working on missions to needy countries. We do about 4 to 6 missions per year, averaging 300 to 400 cases, surgical and interventional. Surgical around 25 to 30 per mission, and interventional between 60 up to 100 per mission to maximize really the use of us going to these countries which are in big need. So just to tell everybody that really rest assured that if there is a will, there is always a way. And you know, that center in Mukalla, Nabd al-Haya, was really established during the Yemeni war. Good intentions plus good executions result in marvelous reward. And we have seen from the presentations today how much work can be done. And I'll show you also how much work we can do. We, the group of Hearts for Hearts, have done around 8,000 patients. Around 4,000 to 6,000 patients. When the purpose is noble, all forces and resources will be made available to you. So really believe that you can do it. Even when it looks like very gloomy, there is no support, no finance, not many people. Once a group believes in this purpose, you really can do a lot. Our merit in this function that we want to do is these kind of points I'm putting in front of you just to see it. We have to realize that we can realize the issues that are there, look around, survey, and so on. We have to recognize the need. We cannot function by the way we are functioning in our own countries. In Saudi Arabia, we are so blessed to have around 8 pediatric cardiac centers fully equipped doing all modern procedures, whether it's neonates or adults with congenital heart. Cardiac surgery in Saudi Arabia started in 1975, but it's not that in the countries around us. So whatever structures we are used to work with may need to be restructured and re-looked at how to make it suitable to use in missions. Readiness, I mean by that, ready by all means, ready by the group of people who are ready to work, the needed equipment, the needed fund, the needed cover that we work by. You know, you cannot just go to countries as people, you really need to go as an organization or with an official cover to really achieve what is needed. Resourcefulness, never feel that you don't have the resource. There's a lot of resources, and in each person of us, there is a lot of resources, and every bit counts. And just look around. And today, from what I've heard from the meeting, I found for our group so many resources that I would like to tap on, inshallah, after the meeting to achieve much more than we have done. Adaptability to the needs and to the available resources. You don't have to work with your Bentley or your Rolls Royce in these countries, work with a simple manual gear car to do what is needed. Have to be very creative in solving the problems we save, very flexible. Cooperation is the name of the game. Cooperating with everyone, the government, the Ministry of Health, the NGOs, the individuals, the cardiac centers, the world to achieve, because it is, or the lack of congenital heart disease services, especially in the underdeveloped or even middle class countries, is a major problem. A lot of patience is needed in such commitment because it is tedious, it is hard, it takes a long time, a lot of preparation. So if we are short breath or short-sightedness, we cannot really continue. Endure, have a lot of enthusiasm for the group and the team. Rejuvenate, never die old. That means add more resources, especially human resources, to the team, so the team will forever continue, because the team cannot just go for 12 years with the same people who started it. Obviously, we need to be very professional. The way we practice congenital heart disease management, whether surgery or intervention, we do it in our countries in the major centers in a very professional way that shouldn't be affected when we practice it in those needy countries. And obviously, planning is a very important part. So what are the challenges that are there? I mean, this is some of the challenges. There are team challenges, the place, there are disease burden and patient selection, equipment and disposable, interventional procedures challenges, surgical challenges, the families and the social part, the outcome and the sustainability challenges. This is to show you how when we go to any country, our group at least, and this is what I'm advocating, is to connect with everybody, the officials, the community, the colleagues, to be able to go through the channels that will support the continuity. And if you have any issues, you will find somebody to fall back on. This is how the need is. Look at this is our receptionist in one of the missions in Yemen. Look how many people just trying to get or pass a report or take a number in the queue to be treated. Waiting areas are like that with their women and men. Look at these babies and children in their mother's hands. Sitting on the floor, this is a father with two little girls who have not so much of a big congenital heart disease, but they do and they need service. Cooperation, when I said this is Dr. Mark Paquette from Canada. He's one of the major contributors to the interventional part of the missions. These are the hard times when we sit in the cath lab. We don't even have your usual console for recording, for hemodynamics. You have to do it on paper and get to some results that will affect how we send the patient to surgery or not, or what intervention and how to calculate all what we need. Team challenges include, number one of the challenges we really have to strive to solve is the inavailability of enough people to take from and go to these missions. So a large pool of specialists in the treatment of congenital heart disease, whether surgeons, cardiologists, anesthetists, intensivists, respiratory therapists, nurses, name it. You have to have a large pool. Our group is around 60 to 90 people who we choose from for every mission and schedule. And that really makes it easier to make these missions sustainable. You can plan well. You can say, I can go to this country 4 times, to that country 3 times, because you, in advance, know who the people are needed. The team specialties have to be complete. This is a challenge to me. We are there to do cardiac surgery and intervention. We are there for an outcome. We don't want to go there and just do surgery or do interventions. We need an outcome. We need to benchmark with the international results. So all specialties are needed. Don't spare on such an area. If you need all the specialties, whether it's the surgeon, the assistant surgeon, the anesthetist, the technician anesthesiologist, the anesthetist assistant, a separate team for anesthesia for the interventional cardiology guys, and so on. So the message here, take all the specialties you need. You cannot meet the challenge of such complex cases, late cases, complicated cases, already with morbidities, without a full, well-trained team. It may sound like it will cost you a lot. Actually, it doesn't, because we overcome the cost by other methods. And I think my brother, Dr. Abdurrauf Saidi, will speak about that. Does number matter? Yes, number matters. Small groups going to missions in these very difficult areas can have a lot of problems. If you take one interventional cardiologist and he gets a flu, you will lose 2, 3, maybe 5 days of the mission. We cannot afford to lose that. We are going there to do numbers. So to do numbers, you need numbers. Our team, for a big mission, like not a mini mission, which includes surgery and interventional cardiology, consists of at least 24 individuals and up to 32 individuals to cover all our needs, because there you cannot work only working hours, 8 to 5. You may work actually 8 to 10, and you add hours to utilize the presence of such a team and to really make a dent in such a big need in these countries. Leaders and subgroups. No single leader for a team can really meet the challenge needed. So we divide our group into subgroups, and each subgroup has a leader and a small committee, if you want to call it, or a task force that deals with all the issues. So anesthesiologists deal with their problems, surgeons do that, along with the perfusionists, cardiologists do their part, and administrators do their part. And all of them are included in a board that governs the group to make sure that we can reach. Maximum utilization is a big challenge for a team. No one is going to go there to do a few procedures or contribute a few hours. No, it's going to be your maximum, maybe 12 hours a day work. And not only that, we utilize the local team, and that helps in 2 points, training them and making them better for the next mission and for their own procedures. And it actually adds to our team another team. For sure, if you want to keep the team well and overcoming all challenges, comforting the team is so important. So the place they sleep in, the food they take, sometimes even the recreation. We sometimes take our team after 9 o'clock p.m. to go and take some food in a place which is nice or with good food, just to make sure that they rest for the next day. You may say rest is sleep, but rest is not all of that. Rest is really feeling happy and having that kind of a family group feeling to make sure that we all go back with great spirit to work. Place challenges. The suitability of the country or the center we go to is so important. We do cardiac surgery and intervention, so and we go in a big team. Dr. O'Kelly has pointed out to the security part in his talk, and one of the most important challenge we have to meet is safety of the team. If that is been charged or something bad happened to any of the team, you may lose your volunteers for your next mission, or you may have problems with the government or the MOH or whatever. So many issues. So safety in choosing the country is a very important part. The country that has good airports to land and good customs and good cargo. You know, we tried so many times to go to Mali, which is in the middle of Africa. One of the major issues to going to Mali is there is no direct flights. You have to fly so many countries before you reach there. And that's a big issue because the team will go there already tired, and coming back with a tired team through all of this may actually give a negative thing. Not to talk about suitability in terms of the presence of a cardiac center, even a simple cardiac center. There has to be a cardiac OR, there has to be a cath lab, there has to be some sort of an ICU and basic equipment that we can build on. And this is my next point, the minimally equipped centers, we can build on. We can bring bypass machines, we can bring rhythm interpretation machines or pacemaker interpretation machines. We can bring those things, but we cannot build up a cath lab. But if we think that the country is worth investing in, like in Yemen, you can actually take few months to build up the cath lab you need, the OR you need, or add to them so you can get more cases and so on. We send surveys to these countries before visiting them in exploration visits to really assess assess what is there on ground. And we don't satisfy with that. We go and visit. We send a team, a small team, cardiologist, an intensivist, and a surgeon to make sure that when we are coming, that these nitty-gritties, these small things, the missing parts are done. We have to have good contact persons in the country we are going to choose, whether these are officials, whether these are cardiologists, surgeons, people who you can depend on and contact to do all your transactions, not financial transactions, your work transactions, especially patient collection and selection. Rules and regulations in the countries have to be well known, and you don't want to be faced that when you go there, they will tell you, well, sorry, you have not fulfilled our regulations and you have to go back. So all papers have to be done prior, visas, licensing of the group is a big challenge, and it may take months to do. So be prepared to do that if you want to go and serve those poor people, and contact the right persons and make sure follow the rules and regulations. Local NGOs are a must for a place not to be challenging to you. So if you want to pass a challenge in the place, make sure you have some connection with local non-governmental organizations or non-for-profit organizations who can help you and actually may help you a lot in reducing your budget and not make it so much overinflated. And they are also a good resource in terms of getting to the community. I remember once we were in Tanzania, and this was a long time ago, before the war between Tanzania and Rwanda, I think, stopped. We could not find blood. And if it wasn't for our NGO there, and they actually called through the mosques and worship houses for people to come and donate, we probably would have lost our surgical mission. Local MOH is very important. You may find a lot of resistance from their authority. So following their rules, their regulation, going through them, filling all the documents and the papers they need is so important. This is a challenge of this is a picture that can show you how much challenge. Do you believe that this is an ICU? This is an ICU, sorry, in Bauchi State, Nigeria. It's basically a pole of metal with hooks where the IV fluid are there. And this is a wooden table where 1, 2, 3, 4, 5, 6, 7, 8, 9, at least that I can count, patients receiving IV fluid. So that kind of country, if you didn't survey it and they have told you we have an ICU, this is the ICU you're going to get. Disease burden and patient selection challenges. We go there and find tetralogies who are 16-year-old, who are 18-year-old with all the polycythemia or the dysfunctional RV, and name it. You'll find a simple PS patient with zero RV function, saturating 66% because of a right shunt across the PFO, and the patient age is already 30 years old, and she had already been pregnant once or twice. So a lot of disease burden is there, and this is a challenge. And the challenge is, where are you going to do these cases? How to optimize these cases? How to get the result? And actually, we do those cases, but we optimize. So for a polycythemic patient, good hydration, venesection, treating any issues before, iron deficiency, and so on. The complex diseases, we in the team have a say in that. I mean, the more complex, and I think everybody almost has the same thing, the more complex it gets actually in these areas, the easier the treatment. Because most of the time, all what you need is a palliation, and you don't have to do in these very complex patients a major surgery. a Glenn may do a great job even in a 12-year-old or a 15-year-old with a single ventricle PS physiology who is so blue. You don't have to do the Fontan. Balloon dilatation of such a PS, stenting, doing a PA band in a patient with complex heart disease may do the job and give you a future opportunity to serve this patient better. Fairness is a big deal in these countries to serve those patients. So what are you going to do? First come, first serve, or are you going to take the most severe first, then the less severe? I think it's a big dilemma. We've reached a middle way in doing. We don't say the most severe, we take the most urgent. I mean, the patient life can be saved or can die if we don't do the procedure in this mission. They will take a priority. On the other hand, we also give priority for good outcome patients like VSDs and AV canals, where we know if you leave them, they're going to be doomed. If you do them, they have an excellent outcome. The selection procedure, we go through that challenge in a very professional way, which I'm sure everybody else does, through case selection, reviewing all the echoes. We send teams prior to the mission to do the echoes and examine the patient. Although there are pediatric cardiologists there who we can trust, but for the selection, we send the team who knows our surgical ability, our interventional ability, and we take care of that through the discussion with the surgeons when we arrive to the country. Huge number of patients is a big challenge. We cannot go there and just do 10 or 15 or 20 patients as a total. It's a challenge to do a lot of patients. And what we found, if you want to do a lot of patients, you have to do a lot of interventions, have at least 2 cardiac ORs, 2 surgical teams, and also take a huge number team, big number of individuals. They can help and work much more hours than a single or a small team.
Dr. Jamil, if you can conclude, we are run of time, please.
I will close soon. Equipment disposable challenge, where to get it from. The same country is the best place, or from international areas. We depend on international brokers to talk to the mother countries to bring it. It's actually even much more less expensive. How to deliver it and what should be included is other challenge. You see, these are the boxes. We sometimes even fly with our own equipment. We put them on air freight cargo and just take them with them to make sure that when we reach there, they are all there and there is no delay. Interventional procedures, the challenge is that we have to do large numbers. The scope should include even some surgical procedures that cannot be done and we cannot delay, like RVOT stenting for tetralogies that we couldn't do because we don't have the time. We even modify our techniques to lessen our fluoroscopy time. Like for a PDA, we no more do aortic injections. We just do it all totally from a right side. And actually, Dr. Ali Al-Akhfash has published our techniques. And I think those techniques were the fruits of such interventions. And obviously, we bring all disposables, all needed equipment to make sure that that challenge is well met. Surgical challenges, choosing the patients, the type of procedure, the number of rooms. As much you have more than 2 or at least 2 is good, because even if you have 1 team, you can actually prepare the other patient in the other room, and the surgeon will just jump between the 2 rooms and do the maximal patient. The pump run is an issue that we found. We cannot take long pump runs, even for difficult cases. We have to have fast surgery. Complications we know are met with long pump runs. And in these areas, if you have complications, the survival is really, number of ICU beds, we ask for at least 4 to 6. Below 4 may not be so fruitful. Early extubation techniques and decreased length of stay techniques is the way to meet the surgical challenges. You see Dr. Abdurrauf Saidi here, he's bringing his own patient by himself to the OR, not because we lack porters, but you will be surprised that some patients will be swapped for others. Some people are actually are so corrupted that they want their relative to be done. They have the same diagnosis and they will replace the patient you have already discussed. And sometimes you may have to go and make sure that the patient you saw is the patient that's going to be put on the table. Involving the team, the local team, very important resource. Doing sophisticated equipment. You see, you can have sophisticated equipment, ventilators, and everything if you prepare well to meet the challenge. You can see from those pictures, you may say, well, this looks like a very fancy OR. This is in one of those underdeveloped countries. Social challenges, family expectations are high. They think you are there, you're gonna cure everything, you're gonna do everybody, so be prepared. One of the most important challenges for them, they come from far areas in their countries. They don't have houses or lodgements and they lack food. So having the NGOs with you to take care of it is so important to make sure that we care for the whole family, not for just the child. This is how poor they are. This is a gas station, smuggled petrol in Nigeria, a country where oil is produced. Security. To move in such countries, you may have to have very tough security. Look at us here in Nigeria also. Talking to the officials, this is the ambassador of Saudi Arabia and Yemen, and connecting with them is a very important issue. Media is a great help for you to go over the challenges and give your message and get more support. And this is how we celebrate the end of the day. We go and have a nice food in any nearby restaurant. And there are ones, even in those underdeveloped countries, that can satisfy your need and appetite. Outcome challenges, to get a good outcome, basic equipment, needed personnel, needed disposables, case discussion and selection, the optimal procedures. It doesn't have to be the procedure need to be done. It's the optimal procedure for that child. Gradual build up to benchmark. We started with about 8% mortality rate. Today we have less than 3% mortality rate. The after mission team is a very important challenge to meet. If you want good results, make sure that you leave a complete team after your big team leaves to discharge all patients safely. I stop here, and these are the little ones that we work for, and they're thanking you for all the good things you have done for them. Thank you.
Thank you, Jamil. Excellent talk. Really, you are doing a great job as usual, and many things that can be said. Unfortunately, because of sake of time, we have to continue. Now, Dr. Abdurrauf Saidi will speak about the administrative and financial challenges in doing charity mission. Dr. Saidi, he's a senior consultant pediatric cardiovascular surgeon at King Fahd Armed Forces Hospital in Jeddah. He's known to carry on, and he is very generous to carry on a charity mission in Africa and Asia and many other regions. Most welcome, Dr. Abdurrauf. Go on.
Thank you, Dr. Milad. Do you see me?
Yes, go on. Yes.
Do you see my slides?
Yes.
Okay. First of all, I want to start with thanking the Congenital Heart Academy and the Pachda for inviting me to speak about humanitarian missions in Middle East and Arabic countries. Though most of our missions are either in Yemen or in Africa. I want to start with a little bit of, where is that? Sorry. I want to start with a little bit of history. Few knows that Open Heart Surgery in Saudi Arabia started with a humanitarian mission. That was in January 1976. A Loma Linda University heart team led by Dr. Wareham and Dr. Cogan. Wareham was the surgeon and Cogan was the pediatric cardiologist. It was in Khamis Mshed, 250 cases and only 2 deaths. An amazing result. At that time, there was no even a 2D echo. Now, what are the strategies in treating congenital heart disease in developing countries? First of all, you may send the patient to the country, to other countries in which available and had still be done like what Dr. Sadiq alluded before, or you can send a team like what we are doing. But all these are only one step to the major goal is to establish a regional creation of regional center where is the patient left and residue. And this is all come with the training of local doctors and developing the pediatric cardiac services in that places. Sending a team to developing countries is not without challenges. Many of these challenges, Dr. Jamil talked about it. Law and permission, recruiting volunteers, finding suitable partners, identifying hospital, host, local politics, language barriers, maintaining acquired skills. The list is going on and on to ethical challenges, governance, and others. So I will take some of the most practical issues that we are looking for. First of all, legal and regulatory challenges. Since 9/11, it became very difficult to establish non-profit organization that works across borders in Saudi Arabia. So what's the solution? The solution is to find a partner or sponsor, and you have to be so much flexible to change from partner to partner with time. Sometimes one sponsor is not enough, and coalition or joint venture is crucial. We started with Hayat al-Ighatha or Islamic Relief Fund, and after a few years, we changed to Al-Muntada Aid, which is a UK-based institution, non-profit organization. We established a Little Hearts program, and still we are working with them, but much less than before. And then nowadays, King Salman is the only official organization that in Saudi Arabia that you can go through it. Still, Riaya, which is belongs to Muslim leagues, can work, but through the King Salman Humanitarian Aid and Relief Center. What's the function of non-profit partner? Marketing, donation, collection, logistic and supply chain management. But this does not come without payment. You have to pay. For one thing, you are not the only project with them. So you have to find a solution and sometimes a joint venture between non-profit organization in different countries. Local partners is very important in either non-profit organization, Ministry of Health, or any government agency. And these could recruit patients for you, help in custom clearance, help in visa issue, help in transportation, security, and social events, and support the families with food and housing. All this is very important for you. Now, the second challenge is building a team. We know that there is a discouragement from local employer that their employee goes for charity mission. And we know that usually they refuse to give a humanitarian or a charity vacation, which is 1 month, which is by law, but most of the employer, they refuse. And we know that we have a different types of volunteers that group together in one team. These are medical, non-medical volunteers, trainee, resident trainee, and donor volunteer. Also, you can see them. We have more than 80 volunteers since we started the program. We have from 8 centers in Saudi Arabia, from 6 other countries outside Saudi Arabia, 14 nationalities at one of the missions we calculated. Medical volunteers could be surgeon, cardiologists, intensivists, anesthetists, nurses, RTs, eco-technician. We have a 5-2 rule that for seniors, we ask for 5 years experience. For juniors, nurses, RTs, we ask for only 2 years experience. We have a company seller technicians who are coming with as a volunteer. And this is one of them, maybe Mr. Theo, who is a retired Dutch cath lab technician, is a seller. He's now coming on a regular basis with us. And in fact, he comes with all the supplies of the cath lab. And at the end of the mission, we pay for him only what we consume. And this is, according to Dr. Mansour, reduce the cath lab expenditure by around 50%. Medical volunteers, you should have a database for your medical volunteers. We keep a CP certificate, work license, a passport copy with us in case we need a temporary work permit in the country that we are going to. Medical malpractice may be needed. Equal opportunity to all participants in the database is essential. Keep a sober volunteers that in a late withdrawal, sometimes a surgeon or a cardiologist say, I cannot go, and there is only 2 days before the mission. Then you can ask one of the sober volunteers to go instead of him. Now, medical training volunteer, we accept medical training to come with us, but we should utilize them according to their level of training and abilities. They should not compete with the local training, and they have to know that. And it is nice if they have if the mission period and logbook is recognized by their training body. Non-medical volunteer, mostly of the people you see around you are employee of non-profit organization, but still you can see a volunteer in logistic and supportive services, media specialist, social worker, media, social media influencer, security, travel agency, and even intelligence agents, you can see them in the missions. Volunteers' rights and liabilities. Volunteers should sign a contract for rights and liabilities. They should receive a clear instruction regarding ethical conduct, sensitive cultural and religious differences in the country they are visiting, travel safety, rules of using photos, social media, clarify rules for all participants. Volunteers' rights and liabilities, we give them free tickets, accommodation, 3 meals per day, laundry services, malaria prophylaxis, and relevant vaccine. Always take with you a bag of drugs for traveler diarrhea, for flus, and for asthmatic attack, an allergy for your own team purposes. Choosing the country, safe. We don't operate usually in a hot war zone, but we go to Yemen, to Hadramaut, welcoming medical staff and government official, essential for both of them. Cardiologist is very essential to have a cardiologist. This is Dr. Sulafa Ali from Sudan. We worked with her a lot, maybe 12 missions before, and she is a welcoming. She is one of the great brains in Sudan in pediatric cardiology. And this is Dr. Noor Nahar, Fatma Noor Nahar from Bangladesh. She is established of non-profit organization helping kids in Bangladesh. And this is Dr. Mariam Ahmed Saleh from Mauritania. She's having a charity mission for pediatric in Mauritania. And this is Dr. Al Hamadi. Luckily, he's the only male that I referred to now, at least when we have one male. Is in Yemen, and he helped us since 2007, February 2007. Challenges of choosing the hospital. We start with filling site assessment paper. We send it to the local team, and then followed by step 2, site visit by 3 senior team members, and then step 3, agreement and contract. filling the assessment paper. We have an assessment paper that we sent to all hospital, and then after that we go and see, visit the hospital by a senior team, and then after that discussing a contract with the local authority and check accommodation, transport, security, and other things that outside the hospital. I want to mention some that people tend to forget that, for example, when you go to the hospital, check, for example, electricity, main power supply, do they have a backup generator? Do they have external UPS? What is the switch time? Apparently, switch time, once we have a switch time in Yemen was 30 seconds. This was too long. It should be a seamless transition between the power sources. And we know that for cath lab, it needs around 5 to 6 minutes for rebooting of cath lab. Luckily for cardiopulmonary bypass, most of them, the recent new one, they have built-in battery that could power the main pump for at least half an hour to 1 hour. But nevertheless, if you have an issue with electricity, buy some of the UPS, take it with you, 2 for OR and 2 for ICU. That should help you a lot. Oxygen source and cylinders are very essential. Be sure that these oxygen cylinders are filled before you come to the mission, and they have a regulator with them. Water supply, this is me scrubbing in an area we didn't find a good quality of water in OR, so I am using a low salt IV drip to do the scrubbing. Others forgotten services, blood bank, lab, radiology. They should have HIV, Hep C testing, sterilization services are very important to know about them. We take with us nowadays a temporary pacemaker. We take 2 at least extra flip-up loops with us, and the LED light source. We have our own portable echo machine. Nowadays, we carry also a couple of ventilators, portable ventilators, and couple of ABG machine, handheld ABG machine from Abbott. Intraoperative echo is a critical issue. So what we are doing is we developed our own algorithm for doing an epicardial echo using gloves and a sleeve from the drapes itself. The second challenge is alignment of goals, and this is a very important. The team's goals may be different from host goals, so listen to them and try to align goals with the host goals. Some countries, they don't need expertise. They need only support of single patient. And that's what we realize in some countries like Egypt. Maintaining a long-term partnership is very essential. If you go to visit a center, keep the relationship 3 to 5 years till the center take over by their own team. Buy medication supplies from the local supplier. This will help the country companies in importing more for the cardiac surgery and pediatric cardiology items. Leave reasonable amount of supplies like sutures, grafts for the local use. Make sure that your mission will not stress on the local hospital budget, and this is a very essential. Challenge number 7: supply chain managers, very problematic, interrupted business deals, different surgeons with different practices, different routes of supply chain may impede on your supply chain, so you have to be sure about having a better supply chain. So the delay, airport mishaps, custom clearance, or issues with the supply chain. So transport your consumable early before the 2 weeks at least. Local partners should clear them from custom and should be stored in a safe place inside the hospital. We have 2 partners, Care to Consult and Cardio Plus in Western Africa, Care to Consult from Dutch, that help us in having our supply chain. Ethical issues. Ethical is very important, choosing the patient, consent, Priorities, media, photos, all these are very important. So selecting the patient, I am pragmatic and utilitarian the same. So we do complex surgeries if they have a good long-term palliation. Complex surgery with no good term palliation like a Fontan is questionable, but we did the Fontans. We prefer to do for single ventricular glen a supplemental blood flow as alluded by Dr. Jamil. Down syndrome, initially we started we have a mortality after the team departure from Down syndrome. Then we stopped doing Down syndrome. And then after that, after we started to adopt a late team policy, we started again to do surgery for Down syndrome. Media could be very helpful, but could be harmful. So obtain a permission and photo from family and the patient. Media should be discussed with the host and avoid undermining the effort of local people. News briefing should be combined. Social media influencers are very important for good advertising. Try to make short story documentary at least once a year. And this is a very essential. Local politics, as Dr. Jamil showed this photo, this patient was cancelled twice and replaced by another patient. So you have to accept this. And you have to find your way how to help the patient. You may stay with an official most of the time, so you have to know what to talk and how to handle this situation. Language barrier. Did you ever work in a hospital with no single paper, English paper in their files? Yes, this is one. This was a hospital OR list in one of the Central Asian countries. They refused to put any English paper inside the files. So what the solution is to have a parallel notes and this parallel note having an English in it. Challenging cultural differences. You have to respect host culture. Contribute instruction volunteers regarding respect culture and religious issue, and read the trip advisor before you do your trip itself. Quality assurance is very important. Standardize your forms, eco-report, OR, and protocol-oriented post-operative orders. Very important for you and for the team, the local team, to build on it later on. Quality assurance, you should have your own database, frequent assessment of result. CQI procedures are very important. This is our mortality, as Dr. Jamil said. This is from Little Heart program. We did around 2,172 patients, 760, there were, these are surgical, 36 were excluded, 23 mortality, 3% of the mortality, and what was within the acceptable at international level. Mortality after the team departure, we adopted the late team policy. We send an early team to screening and see the hospital premises to see whatever we can bring with us, and the main team and late team, mainly ICU specialists, nurses, cardiologists, and surgical specialists. Financial issue, Little Heart program, 31 missions. The cost is 2,000 to 2,500 per patient, and this is the cost of the patient. This is the Excel sheet of it. If you want this smile of the kids, you have to pay, and you have to pay from your time, from the money, and 2,000 to 2,500 is too little to pay for a smile from beautiful kids with a beautiful smile. Team expenses around 26 to 35%, consumable 70%. Cost containment techniques and lean production, very important, and that's what we are going to, we start to adopt in the last few years. This is a gradual decrease in team size as the host team mature. Long-term contract with suppliers for purchasing power. Approach airlines, hotel, travel agencies, accept and seek donation from hospital for refurbished. I remember we have to buy a refurbished for one hospital in Nouakchott that cost us a refurbished ventilator, $5,000 US per ventilator, to be shipped from USA to Nouakchott. In conclusion, medical charity mission combine both challenges of nonprofit organization management and healthcare setting complexities. This results in a unique set of challenges, from formulating a strategy for the missions to auditing the result. These challenges can be overcome with a comprehensive approach for planning, execution, and keep in mind both ethical and financial constraints. I want to thank all the group that helped us in this charity mission. They are more than 80 individuals from different nationality. And I want to thank the Congenital Heart Academy and Pachda for giving us this opportunity to talk.
Thank you so much, Dr. Abderraouf, for this nice talk. It really came from a vast experience in planning and performing such missions, you and Dr. Jamil. Now, I hope we stick to time. The talk is about Dr. Maïl Sayed. She's a professor of cardiology at Shamsi University. She's the president of the Egyptian Working Group of Pediatric Cardiologists and the moderator of the Egyptian Pediatric Cardiology Fellowship in the Ministry of Health. Dr. Maïl, please. Maïl?
Thank you, Hela, for the introduction. I'm trying to share my screen now. Now, can you see me?
We see you, but not the screen
Okay.
yet.
The screen is shared. It's supposed to be shared. Is it shared?
I didn't. I didn't see it yet.
Unshare and share again, May.
You see it?
Share again. I'm sharing again. Now you can see me? Hello?
No.
No. Share. Okay, I'll cancel and try again. So that's share. Now, can you see me?
Yes, you're starting sharing. Okay, yes.
First of all, I would like to thank the Congenital Heart Academy, Pachda and Hala, Sasha and Grace for organizing this lovely meeting. I also would like to thank all my previous colleagues who had wonderful presentations. Just a bit of a change of theme now. My talk will be about catheter interventions in late presenters of congenital heart disease, and I have no disclosures. Well, in our part of the world, timely diagnosis and early management have improved a lot over the past decades because of increased awareness among pediatricians and neonatologists. One important factor was the social media with parents group, and they talk together and they search for surgeons and pediatric cardiologists. And there is an establishment of several expert centers among Egypt with for congenital heart disease, both in intervention and surgery. Most of them are localized in Cairo, but we have all over the country. And of course, there is the Aswan Heart Center, which is the charity organization. The budget for these come from the Ministry of Health, from the insurance, from NGOs, from Azhar Zakat Fund. And also recently, the government has adopted a central buying policy, which will make stuff even cheaper. And we will be able to do more and more cases. Despite the improved care, we still see a lot of patients. So who are late presenters? Late presenters are referred to presentations late in the natural history of the specific cardiac defect with consequent transient or irreversible hemodynamic and pathological alteration that would impact the medical and surgical approach, risk, and outcome. And I've taken this definition from the paper which was published in Cardiology in the Young. So why is that? Because of late diagnosis and referral. limited resources and infrastructure in surgery, the availability of devices, the geographic factors that preclude timely diagnosis and transfer to a cardiac center, especially in Egypt. We have people that are living in Sinai, they are living in the oasis in the Western Desert that cannot come to the express centers. And the low level of awareness of parents and appropriate medical advice. This is another factor. There is a very, when you get a patient that has come to you late, and there is a very familiar phrase to all of us is that defects will close in time and there is no need to intervene. And then suddenly the patient develops Eisenmenger syndrome and he's blue and he comes to you. And then there is the fear of open heart surgery or intervention. And this is the stigma it carries, especially in females. And this is very common to our part of the world. So what are the commonly seen cases referred for intervention or hemodynamic studies? There are the duct-dependent cyanotic heart disease who present late. Eisenmenger syndrome, of course, is on top of the list. Shunts. I have a patient who is 45 years with truncus arteriosus, double outlet right ventricle, late phallus, etc. Left to right shunts with pulmonary hypertension also is very common. Coarctation of aorta is commonly missed, and we mostly see them in the 20s and even 40s and 50s with their complications. Missed severe CPS with cyanosis. I've done 2 patients who were pregnant actually, and they did not know that they had syncopal attacks and was told this is on account of pregnancy, but they turned out to be severe PS and we had to do them when they were pregnant. And then cyanotic heart disease with poor mixing and post-operative missed lesions or post-operative complications due to lack of follow-up. So this is a typical case scenario. It's an 11-month-old girl presenting with sudden onset of cyanosis. Her echo multi-slice CD showed atrioventricular septal defect, pulmonary arteries and origin stones at the left pulmonary artery and bilateral SVCs. She presented to the ER with deep cyanosis, saturation of 25, confused and acidotic, received prostaglandins, and we were not sure it will work, but it brought her saturation up to 80%. She developed mitral stroke and referred to surgery for bilateral bidirectional Glenn and LPA reconstruction because we thought the duct was too complex to stent, and she was already 11 months. She was fit for surgery, but unfortunately she did not make it. Another case scenario is for inappropriate medical advice. The 40-year-old male, shortness of breath, atypical chest pain. She was diagnosed as, a doctor diagnosed her as possible ischemic heart disease, went for a coronary angio, which of course is normal. She came to us and she had a dilated right side. We could not see a shunt. We went for a hemodynamic and TE, and we found a small sinus venosus, ASD, and all right veins going into the right atrium, so partial anomalous pulmonary venous drainage. So let me show you some of the cases that we've done. This is, we start first with left-right shunts with pulmonary hypertension. This is a 10-year-old male child born and living in Yemen. The child presented with new onset exertional dyspnea, New York Heart Association classification 2. His parents didn't notice any other abnormalities, and he had all the signs and symptoms of pulmonary hypertension with an RVSP of 100 millimeter mercury and a normal pulmonary vein with dilated main pulmonary artery and branches with mild PR. He had a large tubular PDA as seen by his multi-slice CT and confirmed by echo. Of course, we started him on sildenafil and bosentan and then took him to the cath lab for a hemodynamic study and possible balloon occlusion and to test his hemodynamics before and after occlusion. And this is what we had. We had a pulmonary artery pressure of 75 and an aorta of 77 at baseline, which are quite similar. And then following balloon occlusion, after 20 minutes, his systolic pulmonary artery pressure dropped to 60, mean dropped to 43, and his aortic pressure rose to 85 and the mean to 95. He had no desaturation in his descending aorta. Saturation was 92% in the pulmonary artery, so we decided to go ahead and close it. Something is going wrong. I'm sorry, the program has... Can you see me?
Yes, but the screen is fixed.
Yeah, the screen is fixed, yes. I'm sorry for that. I might have to restart the program.
I think so.
If I do that. have to restart. Okay, it's coming again now, so stop here. Can you see that now?
Not yet.
Go back to screen sharing. Now you can see me?
Yes.
Okay, so we decided to go ahead and close the duct. So we used a 12mm device, and our rationale was that the drop of the pulmonary artery pressure, the increase in the aortic pressure, as well as mild drop of pulmonary vascular resistance. He had no desaturation after closure, and the patient was still kept on sildenafil and bosentan, and he had good follow-up but we're still on pulmonary arterial hypertension medications. Next study, which is very common also, it's ASD in the adults with mild pulmonary hypertension. This is a 39-year-old male presenting with palpitations of 3-month duration, systemic hypertension, and he had a Holter monitoring and had episodes of atrial fibrillation, so he had all the complications of an ASD. T showed a large scandum ASD and referred for transcatheter closure. We took him again to the cath lab, and he had a pulmonary vascular resistance of 2 Wood units with a mean pulmonary artery pressure of 30, but with a end diastolic pressure of 20, which was a bit alarming. But we decided we measured the ASD, which was 35mm. We decided to put in a fenestrated device because of the high left ventricular end diastolic pressure and the elevated pulmonary artery pressure. And this is the procedure itself. Now, this is the device being deployed. And then you can see the fenestrations here, and you can even see the fenestrations on 3D echo, and the device is securely in place. Following surgery, missed lesions can lead to pulmonary arterial hypertension. This is a 15-year-old girl which diagnosed as ASD and PSD as a child, underwent surgical closure about 10 years ago, and improved with no follow-up done because most of the parents or some of the parents do not bring their kids for follow-up, assuming that the problem is over. And this is another problem we have in our part of the world. She recently presented with shortness of breath and palpitation on exertion, and she had also signs of pulmonary hypertension. Her echo showed a missed large apical muscular VSD, which was not detected at the first surgery, and severe pulmonary hypertension. She was again put on pulmonary arterial hypertension medication. And we went for a hemodynamic study which showed a pulmonary vascular resistance of 4.5 units. And we went ahead and closed the defect using a muscular VSD device, which was a little bit deformed here in the apex of the right ventricle, but with drop of her pulmonary arterial pressure, which continues to drop with time. Coarctation of the aorta is another subset of patients that we very commonly see presenting very late. This is a 37-year-old engineer. He was hypertensive and not responding to medical treatment. He was just diagnosed as primary hypertension and taking medical treatment. He had a missed coarctation. The multi-slice sheet showed a very tight coarctation, as well as 3 native aneurysms, as you can see here on his multi-slice CT. We did an MDT meeting, consulted the surgeons, and they decided that we can go ahead and try and put in covered stents. So what we did is we took him to the cath lab. You can see here the huge aneurysms. We thought we could first cover it with 2 covered stents. We used first a 45mm CP stent, but then you can see still there is some dye going into the aneurysm. We put another one in the arch so we can have this curve. And then we still had some leakage down here. So we decided to put another long 45 CP stent. And this was our final result. He did not have any aneurysms anywhere else. He's still on antihypertensive medications, but at least we've excluded the aneurysms from the aorta. Another patient with coarctation of aorta is a 40-year-old male complaining of severe attacks of chest pain and shortness of breath, admitted to our hospital with an arterial blood pressure of 170/100 and an unequal pulses. Dissection was suspected. He had a systolic murmur, and his ECG showed left ventricular hypertrophy and multiple PVCs. Echo showed an enlarged aorta, and from the suprasternal view, you can see the dissection here with the false central lumen. So we took him to the multi-slice CT. With the dissection, I had a call from our colleagues in radiology saying, I have dissection. I said, yes, and we just want the entry at the exit point. He said, no, there is something else. We have severe coarctation of the aorta as well. It was the first time for me to see dissection as a complication of neglected coarctation of aorta. So what we did is, this was done actually in Aswan Heart Center with Prof. Magdi Yaoub. We went first in and put in the stent. We were very careful in crossing and only hand injections, and we had the stiff wire parked in the left subclavian artery. And then we deployed our stent with good results. The patient was, the pressure dropped from 90 to 5. The patient was then transferred from the cath lab under anesthesia to theater, where he had replacement of his ascending aorta above the coronary sinus with a 28mm graft by Prof. Yacoub. And this is the final result, 1 month follow-up, and you can see the aorta is fixed in place and the stent is doing nicely. I think with coarctations, with senior atresias, we've done about 10 cases. Most of them were discovered during routine coronary angio for acute coronary syndrome. And then we take them to the cath lab. Most of them, we first do an injection from the subclavian, both from the brachial and from the femoral, and different views until we align them together. And then we try and cross either with a stiff end of the wire or with, like in this case, with a CTO wire to come from above to below. And then we snare the wire in, change it for the stiff wire, and then put our stent in. They have been very rewarding in these cases, and they really did very well. Another patient here with poor mixing. This is a 14-year-old female. This was an interesting case. She had Down syndrome, diagnosed with AV septal defect, cotriatriatum, and restricted PFO, causing poor mixing. You can see from her echo here that the left atrium and left pulmonary veins were completely excluded from the main circulation, and with only a small PFO. She was deemed inoperable as a child because of severe pulmonary hypertension. Of course, this is mixed from the AVSD and from pulmonary venous hypertension. She presented in 2015 with severe cyanosis at the age of 9, and we did a balloon atrial septostomy to improve mixing and improved with increased oxygen saturation and mild decrease in PA pressure. She was then lost to follow-up until she was referred again in February 2020, just before the lockdown, from another hospital. She was shocked, acidotic, and desaturated. Echo had very poor mixing with only a tiny defect seen with severe pulmonary hypertension. She was rushed to the cath lab for balloon atrial septostomy and stenting of the anterior atrial septum. As you can see from her TE, there is a spontaneous echo contrast in the left atrium, bulging of the anterior septum, a very small defect in organized thrombus in the right atrium, as well as small thrombi in the left atrium. We had to do this, so we crossed using transseptal puncture, both by fluoroscopic and TE guidance. Once we were in, we parked our wire in the lower left pulmonary vein. We first did balloon dilatation of the created interatrial septal communication. This was followed by a stent, which was a CP stent, 30mm CP stent on a 12mm. First, we started with 12mm balloon, and you can see here there is nice flow across the stent. We later had to flare both the proximal and distal portion of the stent in order to create a waist here so that we do not have the stent dislodged from place. And this was the final result, as you can see from the 3D echo. The outcome, the child was transferred to CCU, mechanically ventilated. Blood pressure was 90/60. Oxygen saturation raised to 82%. Metabolic acidosis corrected and weaned off ventilator on day 4. She had a minor stroke and improved on physiotherapy and was discharged on aspirin. And this is her follow-up echo. As you can see here, the stent is in place, and we have good mixing now from this area. We are planning to do another hemodynamic study and see what happens with the pulmonary artery pressure. If by relieving the pulmonary venous hypertension, the pulmonary artery pressure will drop or not, we're not very sure. But we're waiting for a while until she recovers completely from her stroke to take her again to the cath lab. So all this is not, of course, without complications. Late presenters have a lot of complications in the cath lab, mainly neurological complications that sometimes are pre-existing. Polycythemia is another complication, local vascular complication, lengthy procedure, radiation exposure for the team and for the patient, blood transfusion and mortality. This is a patient with coarctation, and you can see there is a femoral artery tear here. We discovered that his blood pressure was dropping. This was done only a couple of weeks ago. We did manage to pass in a balloon, and after calling our vascular colleagues, I passed a 12-millimeter balloon to control the bleeding a bit, and then was able to put in a covered stent, which was intended primarily for the coarctation. And then he had to be reopened by the vascular team to remove all the thrombi by a Fogarty catheter and relieve the retroperitoneal hematoma. The patient was just discharged from the hospital yesterday, and he's doing well, alhamdulillah. So in conclusion, late presenting cases are often challenging to deal with due to the associated morbidity and complications of the pre-existing congenital heart disease. A lot of improvement in the health sector have been done in the past years in Egypt with free medical insurance for all Egyptian children. And it's even, I think in the next few months, we'll see devices coming in the insurance, because before that, they were not covered by insurance. Stents and devices, we had to go to a non-governmental organization or to visiting team for help with the finances. And with the increased awareness, especially among pediatricians and neonatologists, early detection, we are hoping to see much less case presenting late. And thank you very much. And this is greetings from Egypt. Thank you.
Thank you, Mai, so much for this nice talk. I really enjoyed it. And our next speaker is Dr. Khalid Al-Najashi. He's an adult congenital heart disease and pediatric cardiologist, working in Prince Sultan Cardiac Center, Riyadh, Saudi Arabia. Please, Dr. Khalid.
Assalamu alaikum. Good evening, everyone. Thank you for staying late. My duty is to talk about challenges in managing adults with congenital heart disease. We are part of this world, so we face these challenges as others. I have no disclosure. History in Saudi Arabia started in mid-70s. A military hospital run by MSD in Khamis Moshe. They started the first mission where 100 baby were done, and then followed by Prince Sultan Cardiac Center, where I work. It is part of Riyadh Military Hospital, or what's known now Prince Sultan Military Medical City, followed by King Faisal in late 70s. Both took the lead in congenital heart disease. Late 90s, early 2000, our colleagues in National Guard, which was led by our famous surgeon who's running Cleveland now, Dr. Hani Najm, started the program there. Then currently we have a 12 cardiac center who's running. But as I said, we are part of the sort, so we have ability as those patients antenatally diagnosed. You have an improved surgical outcome, lower mortality. You have an expanding population of adolescent and adult with congenital heart disease. This is where our challenges started. So we have to just inform you, our colleagues, that pediatric cardiology, Prof. Dolberg from Swiss, just published this last week saying that we are expecting 97% of children with congenital heart disease reaching to adulthood. So we need to be ready for those. Now, we learn from practicing adult congenital heart disease that these are a lifelong chronic condition. It's a long way going through, but unfortunately, with a reduced life expectancy, we need to be ready for those challenges. Previously, our mentor, Carol Warnes, in adult with congenital heart disease,
summarize the challenges, that these are surgical challenges in the past. It's a challenges for our current surgeon, where they have to go through redo sternotomies. Challenges for the cardiologists themselves who deal with congenital heart disease in the adult. Challenges also for a minimum practitioner, a minimum number of adult congenital heart disease around the world, everywhere. Challenges for our patients themselves. The challenges is appearing as a variation of anatomy, different type of repairs, pathophysiology are different even in the same lesion, as elegantly shown by our professor, Dr. May, showed that those patients, when they presented in late presentation, they are completely in different shape than when they are early in adult. Progressive lesion with time, aging itself is a matter. They have chronic medical illness, diabetes, hypertension, coronary artery disease. All these are challenges of us as a practitioner in congenital heart disease, as a pediatrician. So definitely you need the multidisciplinary team which constitute of everyone who could help in this. Now, the usual scenario, a 30-year-old PARA Fontaine coming in the night at 3 a.m. with an intractable arrhythmia. Where he goes? Who's going to serve him? Is he the on-call pediatric or adult? Which intensive care is carrying? Is it the adult or the pediatric? So our mentor and professor, Dr. Andrew Reddington, summarized this in 2016, that at that stage, currently, the best result appear to be obtained when you have a patient with adult congenital heart disease who are operated within children's hospital. This has been shown very nicely that these cases, when they operated by congenital heart disease surgeon in a children's hospital setup, they have the best result. They have the lowest mortality. You know, it's not the surgeon. Congenital heart surgeon, when he do the surgery in general hospital, they have the higher mortality. So this is non-congenital heart surgeon who's doing it in a general hospital. Maybe they are better. So we should really be prepared. A hospital setup, we need to be ready. Those patients are there. We have a 12 champion of cardiac center running with an elegant, outstanding result. We have outstanding surgeon whom they are serving the country now, but we need to be ready to have a cover for those volume who's coming. These patients need surgeon, need interventional cardiologist, they need transplantation, they need a special anesthesia, they end up by needing a special psychology. So one of their challenges is that we need to be ready. They are utilizing more health resources. I will go through quickly this publication as early as 2007. Quebec General admission were higher with congenital heart disease. In the US between 2003 and 2012, it has been noticed that increased admission of adults with congenital heart disease. Their drive is congestive heart failure, valvular disease, cerebrovascular accident, where the top admission. They have a long stay in the hospital. They are having a higher cost. This has been shown recently in 2018 by our psychologist, Adrian Kovic, with the group that, again, the hospitalization, still it is increasing. These patients, as again, I will refer back to our Professor May when she showed that these patients will consume more of invasive procedure. They have right and left heart catheterization, if you see it. They have insertion of intra-aortic balloon pump. So it has been noticed that the increase of cost is usually because of increased invasive procedure done for these patients. One of our major challenges is dealing with single ventricle patient in adult. These are challenges, both their male and female, elegantly shown here, 1,000 patient with a 40-year follow-up, showed that it's an era effect, as we say, that are a surgical technique, which has been done, the PARA, we're showing to show the worst outcome, while we have Those with an extra cardiac fontan, the lateral tunnel, were doing much, much better. They live longer. Tariq al-Sayed did a very elegantly a systemic review, which showed that, again, the factor which is associated with long-term mortality after the fontan procedure is that there is an era effect. Those who's done before the 1990, those who had a complex, unfortunately, hypoplastic left heart, those who had been pushed more than pulmonary artery pressure of 17 with a poor ventricle function, all these are very clear that these patients will not do well. As you could see here in the same paper, that their driving causes of mortality and morbidity are heart failure, arrhythmia, stroke, and others. Now, recently we are learning from our group who's doing the Australian New Zealand registry. It's an elegant teamwork there with the fontan, where they are teaching us everything about fontan. They have 1,560 patients, showing that 30% of those who will develop PLE or plastic bronchitis, they will die within 5 years or transplanted, but others, 2/3 of them, they could survive in a stable condition. I'm just going through a few paper here, not have a time to go in detail, but definitely, as I said, Professor Riedekam and his team in the Australian New Zealand registry had been teaching us about their group, the reintervention, the pregnancy effect, the nephropathy, and how those patients could do well with heterotaxy. And they think in their group, with their very excellent surveillance, that those patients with the heterotaxis did not much differ from others in their population. Quality of life is a major driving for those chronic disease. Lymphopenia is another issue. Professor Veldetman, who we are lucky having him in Saudi for the past 2 years, also showing us recently the hepatocellular carcinoma and detection in fontan, where it is really a devastating scenario. In spite of this, still fontan will remain the best palliative strategy for single ventricle patient. Now, are we just dealing with problems with all of these? Do we have a solution? The answer, yes. If you establish a management pathway for those adults with congenital heart disease, if you follow guidelines, we are lucky in the adult congenital. We have almost over the past 10, 12 years, more than 5 guidelines. We have the American Heart in 2008, updated 2018. We have the European, when they were calling it 2010 as the grown-up adult congenital. Now adult congenital is in 2020. These are very clear with the impact of mortality and morbidity. This study has been shown in 2014 in Circulation, that after the introduction of 2008 guidelines, the AHA guideline, there has been an increase number of risks of center referral for adult congenital heart disease, which is associated with lower mortality. So we have solutions. We need to be ready. This is again an elegant work statement from the AHA by again Prof. Grossman and another group, where they show us how to do surveillance to those fontan. Don't wait till they come almost dying in your emergency room. No, you need to do the surveillance since they are children, adolescent, and adult. It is very simple. As I am talking now, 2 out of the 6 beds I have in adult congenital, they are a fontan who's worked up with a liver cirrhosis and other issues. So you need to be really ready for their problem. Now, again, returning back to the Australian New Zealand registry. They show the position statement showing to you stages of deterioration and a progression of the disease with those fontan with either their cardiac or non-cardiac. So what is our local challenges of dealing with adult congenital heart disease in Saudi Arabia? Do we have our own data? Is our resources limited? Is the care provided optimum? I think, as you said, our resources, we have currently now, we have center with pediatric, cardiac surgery and cardiology, intensive care. These are the famous four in Riyadh, BSCC, King Faisal, King Abdulaziz National Guard, and King Fahad Medical City. We have the BSCC in Qasim. We have the BSCC in Al-Ahsa, which is Prince Sultan Cardiac Center in Al-Ahsa and in Al-Qasim. We have also Al-Medina Cardiac Center. We have in Jeddah another 4 center, King Fahad Cardiac Center in, King Fahad Hospital, military hospital where Dr. Al-Saidi working on. We have King Faisal Specialist Hospital and Research Center where Dr. Jamil is there. We have also the King Abdulaziz University Hospital. We have the National Guard Hospital in Jeddah. So we have all these centers. I'm not aiming to say that all they will be set up for a center for adult congenital. No, I think we could work elegantly to build a national a network for dealing with adult with congenital heart disease. You have all the infrastructure, all the material available, and I think with more training, you will gain a lot of experience and attract more fellows to be trained. Back to my center where I work, it is the largest in the country, 186 bed, 110 beds for adult cardiology, 70 for the congenital heart disease and surgery. We have a dedicated unit with 6 beds, which is most of the time we are utilizing even beds from our colleagues in adult cardiology, where it is really the average between 7 to 10, up to 10 per week. So these are a patient who need a demand. I'm just sharing with you, these are our average admission per year. As you see it, we started in January 2009. This unit were opened with a 6-bed, 3 females and 3 male. We have an average of 300 to 400 admission the first few years. We reached up to 500. But as I said, one of the legitimate for adult congenital practitioner that you will have sometime challenges, administrative challenges or a regulation challenges where your admission could drop. But unfortunately, those patients, they will come through again the emergency room. We are, as any other place, affected by COVID in 2020, but we are again trying to get those patients back. Average length of stay, we are not different from the world. The average length of stay since the start was between 3 to 5. We are increasing definitely with the complexity and more complex cases than either interventional or surgical. We will reach still average length of stay is around 6.2 days. As a data, I'm just inviting you to, this is our outcomes of Fontan done in BSCC. It's a 480 patient over 1986 till 2015. It's definitely a teamwork, everyone involved. Then the other paper also appeared just recently, the past 2 weeks, an elegant work from our colleagues in King Faisal, where they did the 600 ROS outcome. And this tell you that, yes, you could see the adult congenital is lighting in front. And this is an invitation to all our junior cardiologists, pediatric and adult, that the adult congenital is definitely your a bright future. Again, thank you for listening and for all our colleague and speaker before. Thank you.
Thank you, Dr. Khalid, for this nice talk. And now we came for the end of our webinar. Sorry, unfortunately, we don't have time for discussions, but I should thank the Congenital Heart Academy, Dr. Sasha Agati and Dr. Grace Van Duven for approaching us, the Pachda, to organize such a wonderful webinar. We talked from our experience, from our point of view. I should thank Dr. Rida Al-Uqali and Dr. Sadi Al-Hammash and Dr. Ali Al-Akhfash for talking from the experience in establishing the cardiac surgery and pediatric cardiology service in the war zones. Dr. Jamil Al-Ata and Dr. Abdurraouf Al-Saidi talked from vast experience in providing, organizing, planning, and performing such missions. You did a lot of procedures. We thank you all for this, and came to my dear friend and colleague, Dr. Mai Said, Dr. Khalid Al-Najashi, for performing and for talking about the adults of congenital heart disease. And this is our aim, to take these children, to organize, to diagnose early and take them to adult life in a good shape. I should thank my colleague, Dr. Milad, for sharing me and moderating this session. Thank you, Milad, so much. And I hope we end this meeting in a good shape. Thank you, Sasha. Thank you, Grace. Okay, bye.
Thank you. Thank you, guys. It was amazing. We've learned a lot. Thank you very much. It was an amazing meeting.
Okay.
Bye-bye, everybody.
Thank you, everybody, and bye-bye.
Waiting for the next.
Yes, hopefully, inshallah.
Inshallah, okay.